Welcome to Breakthrough. Today we'll be discussing pearls for reverse shoulder arthroplasty with Patrick Denard from Medford, Oregon, and Tony Romeo from Chicago, Illinois. Gentlemen, thank you for joining us today.
Thanks for having us, Chris.
Thanks, Chris.
Absolutely. Now, with any innovation, we all know there's a learning curve. Patrick, what is your top pearl for glenoid baseplate positioning?
I think study after study has shown, right, that you are going to have the best baseplate position if you use a guide or patient-specific instrumentation. So really that's predicated on having good exposure. You got to have a good straight view of the glenoid. And for me, if I'm struggling, that's all about going back and releasing the humeral side, making sure I can get a straight line approach. But once you have that, if you have a guide, you're going to get it right almost every time.
Tony, what about you?
Well, as Pat said, inevitably in the operating room, you have to have the exposure. But before the operating room, if you can actually visualize the three-dimensional structure of the glenoid with a preoperative plan, and then take that plan and put the glenoid where you'd like it, and then be able to take that and bring it into the operating room with the targeting device, that's going to be the secret to making sure you put it in the right spot. Excellent exposure, a preoperative plan, and then delivering it at the time of surgery.
So those are some great pearls. Now, Patrick, how important is the turnaround and timing of the preoperative plan?
I think that's one of the things that really distinguishes the VIP system and targeting device from other systems out there is you can go from plan to implementation 48 hours. Other systems, you have to get a customized guide that's expensive. With the VIP targeter, you can go right from plan to the case in 48 hours or less.
Now, Tony, as you've gained experience with the Augments, what are some orientation and positioning pearls?
Yeah, the Augments have been a wonderful addition to the system because before, when we had these bone defects, we had to use the patient's bone typically, and it's a bit unpredictable. Metal, very predictable, and fits right into our preoperative plan. And so when we have an augment where we're trying to correct the inclination because it's a patient with cuff tear arthropathy, it's very nice to be able to put that augment superiorly and make sure that we correct it down to zero. In that situation, we'd love to have the screw holes in line with the axis of the glenoid, so that's the standard way that it's developed. One at the top, one at the bottom, and then anterior and posteriorly as well as the central post. However, if that deficiency is more into the corner. So like instead of the 12 o'clock position at the 10:30, 10 or 9 o'clock position, our screw holes are now not going to be with the axis of the glenoid. Fortunately, we have a system where the augment also has an oblique screw hole alignment. So as that augment goes more posterior, you can get the screw holes to be in line with the glenoid and maximize your fixation with the screws.
That's really interesting. Now, Pat, what about humoral planning?
Yeah, Humoral Planning is a new feature for us, and I think what's really nice about that is just another layer of giving you confidence going in the operating room, right? Just like we were doing the glenoid, now we can go to the humerus, get a sense of the size of the implant. That's going to potentially give you improved efficiency. Also, in cases that are more complex, like deformity, we can address that and see if we can get a stem in. So I think it's been a great addition to our technology.
Now, this has been an incredible discussion, but nuances of tensioning are always on a surgeon's mind. Can you both provide your pearls on tensioning and range of motion with our viewers? Tony, let's start with you.
You know, this whole issue with regards to tensioning goes back to the very beginning when it was initially developed by Grammont, and you asked how tight do you put it. Many surgeons say, I put it as tight as I can so I can just barely reduce it. That makes sure that it's stable. But the design was different. It was a steeper inclination at 155, and it came underneath the glenoid. And when we went to more of an anatomic structure, was 135, even the reduction maneuver was slightly different. And what we've noticed, particularly over the last 10 years, is that we put in looser or more lax than we did at the beginning when we were using the different styles. But it's still, when it goes through a range of motion, can't impinge on the scapula. It can't gap off of the glenosphere. And we can achieve that by placing our glenoid in the right spot and then lateralizing it so we avoid the scapula. And that was really some important technology that needed to happen, a 135 inclination and lateralization of the glenosphere. And that, in fact, allowed us to put it in a slightly more lax position, which gave us the opportunity for more range of motion at the glenohumeral joint. And yet we avoided increased instability of the glenohumeral joint.
Pat, what about you?
Yeah, I think just echoing what Tony said, if you look at the literature on dislocation after 135, it's extremely low, right? So for me, I'll confess I do very little trialing. It's all about planning in advance, how much lateralization I'm going to have. That 6 to 8 millimeters of lateralization on the glenoid side with a 135, you're really doing more of an anatomic reverse. And if I do that and I have confidence at the time of surgery, then I'm not going to have an instability event.
Now, Tony, in regards to patient satisfaction and overall patient experience, what are you doing in your practice?
Well, patient experience begins as soon as the patient walks into the door. They have to be greeted properly. They should be put in a room by a medical assistant who knows about your practice. And then once a decision has been made that a shoulder arthroplasty is necessary, they should be educated on exactly what that is and their questions should be answered. Many of our patients still do not know the difference between an anatomic and a reverse. And using models that actually show the two different designs is very helpful. And then we can refer them to websites such as the Arthrex Orthopedia site, which has areas available that are really valuable for the patient. I have some of my own. Pat has a wonderful website too, where patients can go after they leave the office to continue to become educated. And then finally, we assess our providers and how they are getting the right message to the patients through Press Ganey scales, which our patients will fill out, tell us how we're doing, as well as online reviews. And we take those and we continue to evolve and improve our practice to maximize that patient experience.
That was wonderful, Tony. So, gentlemen, any final thoughts on the future?
Couple of things. I mean, I think first of all, you just have to be on board, right? Because you're going to see all of this continue to evolve over time. And if you're behind the curve, you're really not going to see what's going on in the future. Second thing that I'm really excited about is range of motion. Currently, the systems out there really are not assessing range of motion properly. They really have little value because they don't take into account the scapula. So as we develop technology that will account for that, I think you'll actually see a translation into being able to have that range of motion assessed preoperatively to actually being clinically meaningful.
Tony?
I think what's really amazing to me is the fact we've had the reverse prosthesis for now 20 years, since 2003. We are still learning how to do this for each of our patients. In other words, patient-specific design and patient-specific implants based on what is going to give them the best function. We're still learning exactly how to do that. In addition to the overall patient care, we're doing more and more of these cases on an outpatient basis, and that's a really significant improvement for both the way our patients feel about the surgery and the environment in which we do these cases. And the technology continues to evolve in terms of the way that we can actually make our cuts on the humeral side, and then some of the newer devices that we can use both on the humerus and glenoid to make sure our patients get the very best implant.
This has been an incredible discussion. Gentlemen, thank you again for joining us today.
Thank you.
Thank you, Chris.
To learn more about optimizing reverse shoulder arthroplasty through advancements in planning, be sure to tune into our other breakthrough episodes, including highlights on making the case, technique play-by-play, and challenging cases. Thank you for joining us.